Okay. Well, you're very welcome to this session, and I'd like to thank the ESC, in particular Stefan Fedenecker, for giving us this platform to look at three of the hotline sessions over the last 2 days. And I'm delighted to be joined by three of our leading interventional cardiologists in Ireland from three different regions in the country. We have Tom Kiernan, Professor Tom Kiernan from the University of Limerick, Professor Aaron Peace from the University of Ulster, and Professor Rob Byrne from the Royal College of Surgeons. And we're going to discuss three important topics. And I suppose what I would say as a no longer interventional cardiologist is that there's a lot of decision making around anything we do. And a wise consultant who is just about to retire and a non-cardiologist, he once told me this, that it takes 3 months to learn how to do a procedure well, 3 years to learn when to do that procedure, and 30 years to learn when not to do that procedure. Now, I suppose I'm the only one with that amount of years on the clock, so I suppose I might be able to throw in a few times about saying not to do things. But we have three very interesting topics, and the first one, I'm going to call on Professor Rob Byrne to talk about MasterDapt.
So thanks, Vinny, and thanks for the opportunity to talk a little bit about MasterDapt as one of the important hotline studies. I have the privilege to be here in Amsterdam to participate in the studio as part of the team. And one of the trials that I was asked to discuss was MasterDapt. And I think this is an important trial because it looks at antithrombotic therapy in patients who are at high bleeding risk and undergo PCI. And it was led, as you may know, by Marco Valgiumilli and Peter Schmitz. And they did a great job in putting together the study protocol and in executing the trial and in presenting the results here in Amsterdam. I think it was a standout contribution, and it was very well received. So one of the things I suppose about trials of antithrombotic therapy, and I'm not sure if the rest of you would agree with me, but there has been a very large number of trials of antithrombotic therapy in recent years after PCI. And in fact, I've counted about 50 randomized trials, all good quality, looking at different durations and potencies and combinations, and somehow, and sometimes it's reasonably hard to keep up. But the MasterDapt angle is to look particularly at those high bleeding risk patients. And I would say that most of us have become comfortable with using somewhat shorter duration of dual antiplatelet therapy in these high bleeding risk patients. And that's based on data that we've had from stent trials, like Leaders Free or Senior or Zeus or Onyx 1. And all of those trials tended to have abbreviated DAPT, but actually they were comparing stent A versus stent B. And the abbreviated DAPT, and a lot of them, it was about 1 month. There wasn't a comparator group in terms of a more standard DAPT. So while the results looked, in line with expectations, it was difficult to get an idea of whether or not we were missing something by not having a control group in these HBR patients of more prolonged DAPT. So that's what MasterDapt set out to do. And it was a large-scale trial. And they enrolled patients across the spectrum of disease presentations. And I suppose they also stratified according to whether or not you were on an oral anticoagulant. So you might have been on an OAC, or you might have been a high bleeding risk for another reason. And overall, the trial results were quite definitive, and they showed that if you do abbreviate DAPT duration, the overall net clinical outcome didn't seem to be different in comparison with a more standard duration of dual antiplatelet therapy. And then they had a series of hypotheses which they tested, and they used what's called a hierarchical model. And they started off by testing one, and then if that was positive, they went on to test number 2, and if that was positive, they went on to test number 3, and if that was positive, they went on to test number 4. So the advantage of using this hierarchical model is that you don't need to adjust the p-value for multiple comparisons, because you can only move on to the next step if the first p-value is nominally positive. So what they looked at was the net clinical outcome. And then the secondary endpoint that they looked at then was MACE, and said, well, listen, was there any decrement in major adverse cardiac or cerebrovascular events from shortening the DAPT? And they found that there weren't. And if you looked at the Kaplan-Meier curves during the presentation, there didn't really seem to be any signal in terms of major adverse cardiac or cerebrovascular events. So this is a very reassuring finding. Now, when you're using composite endpoints like this, one of the criticisms that can be thrown at you as well, not all of the components of the composite endpoint were equally serious. But I think if you look at the MACE endpoint they had, it's death, myocardial infarction, stroke, or stent thrombosis, and these are all pretty major clinical events. So the next thing then that they moved on to look at is bleeding. And for the bleeding endpoint, they used a relatively liberal bleeding endpoint, which is BARC 2 to 5. So BARC 2 to 5 is any clinically actionable bleeding. And as you would expect, they did show a reduction in any clinically actionable bleeding with the abbreviated DAPT as compared with the standard DAPT. And you might say, well, that's not much of a surprise. But what was a little bit surprising is if you just consider the very severe bleedings, that's the BARC 3 to 5 bleeding, actually there wasn't a major difference between the groups. So it's hard to know if you should read too much into that. But we looked at in a similar trial called ESR triple a few years ago at very similar patients with OAC, abbreviated DAPT against standard DAPT back then. And interestingly, we didn't see a major difference between the very serious bleedings in these patients anyway. So it's a little bit surprising. But overall, if you take a step back, this is a study that maybe confirms what most of us are comfortable with doing. So you could say the mark of a good trial is it tells you something you know already, but it shows that in these high bleeding risk patients that abbreviating the DAPT duration seems to be the right thing to do, and that there isn't a major price to be paid in terms of increasing ischemic events, and all bleeding is clinically actionable bleeding is reduced. So I think there's a strong rationale for having that as your default strategy. And on the other hand, the more standard DAPT, if you had to do it in someone who was at high ischemic risk, a very complicated stenting procedure, last remaining vessel or something like that, there doesn't seem to be a major price in terms of the very serious bleeding events if you had to default to a kind of somewhat longer duration of dual antiplatelet therapy. So I think those are some of the things I took home from the trial. I don't know, Tom, Aaron, if there are any other aspects that caught you from that study.
No, I think that the main thing, Robert, from my perspective is, you said yourself that you're not really surprised by the findings of this year. So, I mean, is it a time now, within Ireland that we're a bit more standardized in the way we practice? And because as you said, there's so many permutations in terms of combinations of aspirin, clopidogrel, aspirin, prasugrel, aspirin, ticagrelor, NOACs, and which antiplatelet therapy. Are we now at a time from a governance point of view that there's enough evidence to say, really, this is what we should all be following?
Yeah, it's a good question. And I'm sure there is something to be said for standardization, but as I was kind of alluding to as well, I think, the absence of very significant differences between the two groups also kind of, rings the bell for individualization of therapy. And like I said, if you have to prolong it for a particular reason, then it's not a completely unreasonable thing to do. in terms of the kind of, you're not seeing a dramatic increase in mortality. So one of the things about these trials that's difficult is that, of course, if you're reducing the duration or intensity of antithrombotic therapy, you expect bleeding to go in one direction and ischemic events to go in the other. And that's why they use this kind of net clinical benefit, which also has its detractors. But you can certainly argue the ultimate arbiter of a net clinical benefit is overall mortality. And in a trial like this, it's notable to look at overall mortality and see that it was very similar in both groups. So it does, there are certain things that we should be doing in a standardized fashion, and you're right to point it out. But I think it give us a little bit of understanding that we can adapt according to what's in front of us, as we're all used to doing.
One of the things, if you look at high bleeding risk, just being over 75 put you into that category, and having a hemoglobin below 11 put you into a high bleeding risk. I mean, they're not ones that I would have jumped out and said they're high bleeding risk people, but clearly they are subgroups. So would that mean your practice from now, anybody over 75 who's had a stent, that you feel very comfortable stopping DAPT after a month?
I suppose the definition of HBR group varies a little bit from trial to trial, and the HBR group is quoted at 20% of our workload, up to 45% of our workload. You base it on what you've just mentioned, Benny. So it's difficult, as Aaron is aspiring to create standardization and governance, it's actually difficult to create a full standardization protocol for a population that's not probably fully defined in terms of what volume of the whole population of patients it is. So it's a little bit difficult. Especially just looking at one parameter, a patient over 75, it's multiple different parameters together. If I could just add one more thing, coming away from Master DAPT, and I know it probably was in the name of the study, but I'm still unclear as to what the best single agent monotherapy is going to be after we have a short term abbreviated DAPT. I know we may have to tailor it for patients, but has Rob or Aaron any thoughts on that themselves?
Yeah, I mean, that's a great question, and we could talk for an hour about that, but we mightn't do that. But in this study, what they did was they left it to the discretion of the operators. When you had your abbreviated DAPT, which meant 1 month, then you could either de-escalate to aspirin or a P2Y12 inhibitor after that. And the most common choice made was to de-escalate to clopidogrel. Amongst the investigators, it was about, I think, 3/4 clopidogrel, a quarter aspirin, and then a handful of patients, as you might expect, got a more potent P2Y12 inhibitor, which you'd probably be trying to avoid in these high bleeding risk patients. So one of the interesting subgroups that they'll present is the outcome according to which type of monotherapy they received after 1 month. But of course, that'll be biased because there'll be a reason why someone de-escalated to clopidogrel or to aspirin. So it'll be reasonably challenging to interpret. But it's generally a valid question to ask. And also in this trial, I think at 6 months, they said to come off all antiplatelet therapy. And again, we're not so sure when the right time is to de-escalate antiplatelet therapy completely in these patients. I mean, assuming there are no OAC, do you continue it out to 12 months, as maybe a lot of us do, and then look at discontinuing? So there's definitely lots of open questions there.
So are you suggesting, Tom or Rob, that after a year, after a stent, that you might stop all antiplatelet therapy, even if somebody is not on an anticoagulant at all?
Yeah, so that's the nuance in the anticoagulation patients. Then, of course, people are more comfortable, and we've become more comfortable with de-escalating antiplatelet therapy completely. And that's the subgroup that I was kind of referring to from Master DAPT, the OAC subgroup, which I think was about 35 or 40%. In the patients then who are HBR by for other reasons, then yeah, it is difficult to know what to do over the long term. I'm sure there is some decreasing returns, and the management of those patients, I think, is also unclear. But probably most of us tend to leave them on a single agent antiplatelet if we can get away with it.
What about the 80% of patients that aren't in high bleeding risk. I think you mentioned that figure there, Tom. I mean, would this change of practice for those people that 1 month of DAPT would be okay in these people? Or is that a wrong extrapolation? That
Yeah.
I mean, is the disease process hasn't changed, whether you're a high bleeding risk or you're not a high bleeding risk. It's still the same endothelial denudation from a stent, and you have to re-endothelialize it and heal it. So you're
Sure.
still
I mean,
looking.
if you look at, even if you look at data that was released this morning from the non-HBR group of the Twilight study, they were suggesting that they would move on to a single monotherapy with ticagrelor in the longer term scale would be quite as efficacious as the 12-month DAPD that we'd all been used to. So the non-HBR group is a very different animal completely to the HBR group in general. And it's difficult to make suppositions just based on the one group.
Yeah, I think Vinny, on that one, the key covariate is whether it's ACS or not. So I think in ACS, we have to be circumspect in non-HBR patients about reducing DAPT duration beyond the standard 12 months that Tom refers to. In CCS patients, of course, we can be a little bit more comfortable. And the other factor to consider is if you are de-escalating, at what time point do you de-escalate? Because after a stent implanted in the setting of acute coronary syndrome, there might be a significant difference de-escalating at 1 month as opposed to de-escalating at 3 months or something like that. So again, I think if it's ACS, we probably want to think about slightly longer before you de-escalate. And then finally, when you do de-escalate, you to a more potent P2Y12 inhibitor or to clopidogrel? And of course, as we all know, the problem with clopidogrel is this complete variability in response, where maybe 25 or 30% of patients don't respond at all. And then those patients are potentially left without any protection at a relatively early time point after stenting. So those are all the things that I suppose that are thrown into the mix. And I think the guidelines are still quite clear. If you're not high bleeding risk and you have ACS and a stent, it should be 12 months of aspirin and a more potent P2Y12 inhibitor. And there is, provision, or there will be provision, I think, for saying, okay, if you want to consider a P2Y12 inhibitor monotherapy as an alternative, then, you should wait a few months and you should probably de-escalate, you should definitely de-escalate to one of the more potent P2Y12 inhibitors than to clopidogrel.
Okay. What about the absorbable versus non-absorbable? I may be out of touch, but just tell me, how does that relate to this change of practice now? I mean, are you using non-absorbable stents? I'm sure you are.
So in terms of non-absorbable polymer or absorbable polymer, I don't think there's a significant interaction. I think all of the stents, the new generation DES that we have that are in widespread use and have large-scale trial data, that there's very little to differentiate them based on whether they have a durable polymer or an absorbable polymer. So I think that's not a major factor. And obviously the completely absorbable scaffolds died a death because of issues with stent thrombosis.
Yeah.
Can I just make a point, Fanny, just in relation to what Robert was saying? I mean, de-escalating to a single antiplatelet agent and putting somebody on clopidogrel, for example, as opposed to aspirin, I think that there'll be a lot of resistance to that from our surgical colleagues, because even though there's probably very little difference in terms of bleeding risk between aspirin and clopidogrel, they seem to be very frightened of clopidogrel as opposed to aspirin. The second point that I wanted to make is that I think that there's a lot of SPRs on here, and my practice has been that if people are in ACS, they get 12 months of dual antiplatelet therapy, unless there's a very good reason for them not to have it. And I think that some of the studies that Robert mentioned at the beginning, particularly Onyx 1, sort of makes me much more comfortable that if it's necessary to interrupt dual antiplatelet therapy, that I do so, but on the basis that both the surgeon or whoever it is that we're talking to, oncologist, and the patient are fully aware that yes, there is a slightly increased risk of stent thrombosis, but it's probably acceptable in the context of why you have to interrupt it. And a lot of the time too, if it's interrupted, I would be emphasizing to them to restart it after they get rid of whatever problem there is, where, you know, if it's a tumor that needs to be removed, that they actually restart the antiplatelet therapy afterwards. So it's just a couple of little points, and I don't know if anybody wants to make any comment.
Yeah,
No, they're excellent points. Sorry, Tom.
There was one point, just to follow on from what Robert said, was this timing of abbreviated DAPT finishing post ACS. I mean, we still have to remember that the first 90 days post ACS is still an exponential curve in terms of recurrent events. So, you know, even Onyx 28, et cetera, we need to be really careful in those patients that we don't abbreviate DAP too soon, especially with the data that we do know that the first 90 days is absolutely paramount with the exponential curve of recurrent events. That's number one. And number two, you know, just to follow on from a pragmatic point of Aaron, I agree completely. Not only the surgeons, but our dental colleagues all seem to have a huge fear of antiplatelet therapy that's P2Y12 rather than just aspirin alone. So I think on a pragmatic level, that certainly has to be thought about.
Yeah, they're all excellent points, guys. Final question to all of you. Lesion severity and complexity, would that influence you whether or not to stop it after a month or not? Multiple, a lot of thrombus, you've done thrombus extraction, you've had a lot of stuff to do, bifurcation lesions, whatever. Would that influence you to say, look, I'll stretch it out for 6 weeks or a month, or Tom's 90 days?
Yeah, I think that's an important factor, and that's where you have to rely on the operator, I suppose, to tell you, yes, this was a particularly complicated intervention, and I wouldn't be comfortable to consider shortening the DAPT. And as I said, if you look at master DAPT, you can say, well, in that particular circumstance, then the outcome in the control group with standard DAPT wasn't so much worse. So if you're particularly concerned, I think that's something you can do. One of the criticisms of master DAPT, I won't go on for too long, is that there was only 4% bifurcation intervention in it. And I wonder if that speaks to the problem of these trials in general, where despite everyone's best efforts, you tend to get a selected cohort of patients who aren't as representative as the ones in everyday clinical practice. And the second thing is all of these trials have a run-in period, whether it be 1 or 3 months. So if you take Twilight as a really good example, in order to get into the trial, you had to be event-free out to 3 months in the first place. So I think that first 90 days is critical, and particularly if it's a complex intervention, you certainly have a strong case for erring on the side of caution.
Okay. Actually, all 3 trials today, you could argue that the patient group that's been looked at does not actually represent real world.
Okay, well, on that somber note, Tom, we're going to move on. Our next study has aptly called, well, I don't know if it's aptly called or not. I mean, it's called Tomahawk, and no better man than Aaron Pease to talk to us about Tomahawk. So Aaron, if you'd present this study first.
So thanks, Vinny. I mean, Tomahawk, and Tom's very disappointed that he's not presenting. But anyway, I suppose, you know, this is a very useful study, I think, again, because it helps to reassure us that we're hopefully doing the right thing. I mean, around 65% of people die who have an out-of-hospital cardiac arrest, and the out-of-hospital cardiac arrest without ST elevation is a bigger group, actually, than those with. And I suppose we get a lot of phone calls out of hours from emergency physicians and from anesthetic people and ICU people who are trying to prompt us to take people to the cath lab in the middle of the night. And really and truly, my feeling is that there has to be a very good reason. So, you know, routine unselected early coronary angiography may actually have a negative effect in that you create risk, and by giving them a lot of antiplatelet agents and anticoagulants like heparin, and it actually may as well delay the identification and treatment of causes that are not related to infarction or ACS. And actually, if you look back, you know, the COAX study that was done by our Dutch colleagues really showed that when you compare the strategy of immediate coronary angiography to a delayed strategy in this specific group, but only in group that have a shockable rhythm, that there was no difference really. And the difference, I suppose, primarily between Tomahawk and its predecessor COACT, and in terms of randomized data, is that it was a shockable and an non-shockable group, you know. So really the research question was, is routine immediate coronary angiography superior to a deferred or selected approach, where you would defer people and they would come to us at a more delayed time? And the primary endpoint in all of this was 30-day mortality. And the secondary endpoint, you know, and Robert alluded to it earlier on in terms of the criticism of composite endpoints, was, you know, death from any cause or severe neurological deficit at 30 days. And really what they found at the end of it all was that they had 554 patients that were recruited. And I mean, the investigators, I take my hat off to the people that do these types of studies, because they're exceptionally difficult to recruit for. And there's major issues in terms of consent of these patients that we can discuss, and assent, that really, depending on where you live in Europe, are different, because there's different legal frameworks behind it. So there was a few people that dropped out. There was about 24 that dropped out because of the consent aspect of things and withdrew their consent. And there were some that just dropped out because of a technical, it was really down to them not completing their randomization process. So if, you know, at 30 days, and I mean, it's quite stark when you think about this, that, you know, the immediate group, 54% of the immediate group at 30 days were dead. And unfortunately, and the delayed group, about 46%. And when you looked at the composite endpoint in the secondary endpoint, you saw that increased actually in the immediate group. This is where you're combining death plus the neurological deficit. You're seeing that 64% of the immediate group fall into that, and then 55% are in the delayed group. And the group in general is a much older group than we would see in sort of the primary PCI pathway, because this is where this tends to sit. And so the median age was about 70. I don't know, and Robert will be able to comment on this better, but it certainly doesn't reflect the demographic and the spread within Ireland. But the arrest to return of spontaneous circulation was only 15 minutes. So it's quite short compared to what I would certainly be used to. 30% were female. About nearly 40% of these people had a history of a previous ischemic heart disease, and about just over half had a shockable rhythm, and so about 45% had non-shockable rhythm. So majority of these people were comatose, by the way, so about 90%. So they were actually ventilated by the time they got to the cath lab. And really, it was very much in keeping with previous studies. You know, that's the bottom line, in that it really showed no improvement in survival in either one of these groups. So I think really what it says to me is that we should be selective, and that we should restrict immediate angiography to definite cases of ST elevation, which we know. And as I said, it's an interesting point that we can discuss, in that all ST elevation was excluded in this study. And I think it's worth discussing that. So really, that's a bit of a summary as to what Tomahawk was about.
Thank you very much, Aaron. I think you've started the questions already. I mean, the differentiating factor is ST elevation. I think what they said was the ones with a ST elevation, 98% of them had a significant lesion on angiography, compared to 58% in the non-ST. So if the ECG has been done, you had some commentary yourself on when is the right time to do the ECG. Should we be doing serial ECGs? What should be guiding us, in your opinion?
Well, I think that, you know, you see, there's a paper published this year, interestingly, whenever I was having a look at this study today, that shows that, the time is actually crucial. If you take an ECG, which invariably happens as soon as people have got return of spontaneous circulation, you will invariably see ST elevation. And if you then wait, and in the cutoffs in a different study from this year, obviously, they took 7 minutes for whatever reason, and then that was tertile 1, and then they took 7 minutes, 8 minutes to 33 minutes, and then the tertile 3 was greater than 33 minutes. So the false positive rate in that sort of immediate ECG post arrest is nearly 20%. So, I mean, if we weren't going to do that, we would be bringing 20% more of these people almost to the cath lab on the basis of ST elevation that were excluded. But in this study, anybody that got an ST elevation was excluded. So I mean, it would have been interesting to see, had they done a second serial ECG, would we see similar, different results? I'm not sure. But that's my practice. I don't know what Tom and Robert's experience of this has been.
Yeah, do you want to come in there, Rob or Tom?
Yeah, it's first of all, just to reiterate, to the investigators, this is a huge body of work to achieve the type of study like this. So they have to be commended for that. Number two, it kind of reiterates what we know already. Out of hospital cardiac arrest, CT brain is normal, no ST elevation. We're not going to bring that patient to the lab. So it reiterates that. It makes us feel a bit of confident about making that decision, that we don't need to rush the patient to the lab. It is interesting in this study that they excluded the patient if there was any transient ST elevation at all, Aaron, which goes along with your point. So even if there was ST elevation on just one ECG and the remainder were normal, then the patient was excluded. It's basically a repeat result of COACT. It makes us feel confident about not bringing these patients to the cath lab as an emergency in the middle of the night. And from that point of view, I think it's well worthwhile, and investigators to be commended highly.
So it's going to give you a bit more time to make a proper decision, is what you're saying, Tom. I mean, without a CT brain, you'd be rushing in, maybe given an intervention and DAPT, and then it could be a disaster. So
well, to be honest,
Vinny, you get a bit more confidence.
It doesn't. It actually, what it highlights is maybe I don't need to take these patients to the cath lab at all.
Yeah,
that's
yeah. But you're basing it on one criteria: cardiac arrest and a normal ECG or a non-ST elevation, no ST changes. And as Aaron said, these things can evolve. These ECGs can evolve. So there's circumstances, electrolyte imbalances, other things that will shift the ST segments. So yeah, I suppose it does make it easier to make the decision as regards you don't have to intervene quickly, but it's based on very little data or on one little parameter. Am I right on that, or what do you think, Rob?
Yeah, it's I mean, I think the message from the study is quite clear. And I think a couple of things to be said about the investigators. Number one, I think they did a great job. So the principal investigator was the guy who really drove this study. He gave everyone his mobile phone number. He said, if there's a cardiac arrest at any time of day or night, just call me and we'll try to randomize the patients. So, he did a great job. The second thing is, and this is important, it was funded, I think, pretty much completely through German governmental funding. So that's something that we need to advocate for more and more, that we get funding to do these important studies. And the DZHK, as they're called, which is the German Cardiovascular Research Center, had a number of hotline late-breaking trials at ESC because they put money into research. And I think that's another important point to take home from this. In terms of the nuances around it, it varies a little bit based on kind of local circumstances. And I'm sure it varies within Ireland, and it certainly varies between country to country across Europe. And so you have to consider that when you're interpreting the result. And I enrolled some patients in this study, and it's of course, the issues around consent are challenging, but they had standard paperwork. I think that's reasonably common in these studies where the patient can't provide consent, and the ethical framework around that is quite robust. but the situation in Germany, for example, is different, where most of the patients were recruited from Germany. The situation is different, where when someone has a cardiac arrest, a doctor goes to the patient on the street. So with the ambulance, there's a doctor in the ambulance, they get out, they resuscitate the patient, they intubate the patient, and then they bring the patient to the hospital, normally intubated. And then the next triage question is on the intensive care, what to do with them. So these are kind of nuances that vary a little bit from country to country. And I can tell you, when we started doing the study, there was some reticence because people were saying, "Oh, we do need to bring these patients straight to the cath lab, but in a timely manner." But I think the period in the study protocol was you had to wait for 48 hours unless there was something major that developed, and some people felt that was a bit of a false constraint. And if the enzymes were rising even without ST elevation, that you should be able to kind of consider taking to the lab at an earlier time point. So those were some of the practicalities, but I think the message from the study is quite clear and generally in line with a sensible approach to the management of these patients.
Okay, so take home message: no ST changes, no lab. Okay, what about ST changes? You don't bring them all? What kind of criteria for trainees would help you differentiate in the middle of the night? Somebody's cardiac arrest, the STs are up, they're going to call you guys. What would you say when not to call or when not to intervene versus yes, we need to bring them?
Vinny, that's a very difficult question. And I mean, people have tried to apply various different futility scores to, this type of thing. And Miracle 2 was published recently that looked at that, where you had a whole host of criteria. But then anecdotally, people will tell you that they had all of those criteria and they still survived and they did very, very well. So I think it's certainly my experience is that there's a lot of disagreement in ST elevation when people are in cardiogenic shock or have had an unwitnessed arrest, or they've had a prolonged downtime, or they didn't have chest pain before. I think it's very, very difficult. You can try to look at things like arterial blood gas and look at the pH and look at their age and whether it's unwitnessed or not witnessed and all the various different other parameters. But in the middle of the night, there's not very much support mechanism to really have that discussion, maybe with another cardiologist, and to make that decision together. Maybe that happens in Germany, or maybe it happens in other countries, but it's certainly not my experience in Ireland.
Yeah, it's a little extrapolation, but basically if we say no lab for no ST, but if you do have ST, we still differentiate who we're going to call and or who's going to get intervention or not. It is divergent. It's a yes or a no. You're taking them or you're not. And there isn't a study to guide you, yet you all make those decisions on a daily basis.
Yeah.
Rob, have you any thoughts on that?
Yeah, no, I agree. It's one of these ones that's it's tricky, and of course you're looking at the bigger picture, how long they were down, what their serum lactate is, what their pH is on arrival, and these are all things that you're factoring into the decision when you're considering futility, despite significant ST segment changes. I think one final thing, because I know we're advanced in the time, is Susanna Price from London gave the discussion, and one of the nice points that she made was when you look at the data tables, you can see that a very high proportion of cases were witnessed cardiac arrests, but a very low proportion received bystander CPR.
Yeah.
And this is something that I think we, again, need to advocate for at a local level, because this is a critical part of the chain of survival.
Yeah, no, I think that's an excellent thing to finish on there, Rob. That was true. I mean, it's a holistic thing. I mean, what we do and when we make these decisions, we have to look at the full picture. And if we're not even doing the basics, like giving them CPR to begin with, the rest is icing on the cake. It's irrelevant. So we're going to move on to the last one because we may have some finishing comments. So my great pleasure to ask you, Tom, to discuss Ripcord 2. I don't know who makes up these names. I used to make them up in my day for different trials, but there you go. Ripcord 2 from Tom.
Vinny, thanks very much for the invite, and thanks to the Irish Cardiac Society. Ripcord 2, yeah, it's kind of an interesting study. So basically, we're on the coronary topic again. Ripcord 2 is basically does routine pressure wire assessment influence management strategy at coronary angiography for the diagnosis of chest pain. And this is a prospective, randomized, multi-center, industry-funded trial from Nick Curzon, Agus Accordia in England, in Southampton, and Rod Stables in Liverpool. And basically, the question is, should pressure wire assessment at the time of angiography make a difference? When they're asking for differences here, the primary endpoints they're looking at are two. One is, was there actually a cost-effective utilization? And number two, did the patient's quality of life improve at all? Secondary endpoints were hard endpoints, but we'll discuss that later. So what we do know is that there are robust data already out there in terms of defer FAME2 in patients that have already been triaged for PCI. So that's a no-brainer. The data is robust. We all use it. It's part of the guidelines. Not as much randomized data for FFR at the same time of coronary angiography. So Nick Curzon and his colleagues, again, they had initially the Ripcord trial back in 2014, which was a proof of concept trial that basically said, basically, can we perform FFR at the time of angiography, and will it make a difference? So this was a small group of 200 patients, and what they found is that basically if you added FFR on top of routine angiography, you would change the patient's management in 1 in 4 patients. So quite impressive, 1 in 4 patients would change management. However, still a small number of patients, 200. And how did the 1 in 4 patients, how did their management become changed? Well, the reality was that they looked at the intermediate lesions that we usually use for FFR, 50 to 70% anatomical stenosis. They found that 50% of the times it was either FFR positive or negative. But they found that anatomically tight lesions greater than 70%, a third of the FFR were negative. And even more, unusual is that 30% lesions that we would often just eyeball and say medical therapy, they found a certain percentage of these were actually positive. So this was where basically they then decided to go ahead for the Ripcord 2 study, which they enrolled 1,100 patients, half of them with stable coronary disease, and the other half were actually what they call stabilized non-STEMIs, people that have no recurring chest pain, no dynamic ST changes, etc., etc. And they randomized to 2 groups, one angiography alone and make your decision, or angiography plus FFR and make your decision. You could argue sometimes we do that in routine clinical practice. The important methodology point I have to emphasize here is that this was a pan-FFR process. And what I mean by that is they FFR'd every epicardial vessel that they felt was stentable or graftable, as in a 2.25 millimeter vessel. And they FFR'd all lesions in those vessels, be they 30%, moderate 50 to 70%, or indeed high grade lesions based on coronary anatomy. So that FFR process, kind of a pan FFR for the epicardial vessels, was very much a mechanistic part of the trial, but probably, well, I certainly feel is not part of everyday FFR life for your busy operating interventional cardiologist. So anyway, what did they find? The results, basically, the co-primary endpoints were, number one, the total hospital cost of angiography versus angiography plus FFR at 12 months, there was no difference. Patients' improvement in quality of life in the 2 groups, no difference. Improvement in patient angina at 1 year between the 2 groups, again, no difference. And the secondary endpoints, which were the clinical endpoints in terms of death, stroke, MI, and unplanned revascularization, again, there was no statistical difference between the 2 groups. However, the obvious differences between the two groups were that in the group that had angiography and FFR, procedures took longer. There was increased radiation, increased use of contrast, and there was a higher risk of adverse complications to about 2%. So basically, the take-home message is that FFR as part of routine assessment as a management strategy for chest pain at coronary angiography is not worthwhile in terms of total hospital cost and in terms of improvement in patients' quality of life. So that was basically the take-home result of this trial. But there, there's a few really important points that I just want to bring across that are very important. So why is there no difference in the groups? So you're doing angiography alone versus angiography and FFR, and then making your management decisions, and there was no difference in the groups. So it's hard, you need to try and come up with an explanation for why there was no difference. And if I can give you my few pearls of wisdom, number one, I feel the FFR mechanistic strategy, for example, they did a median FFR of 4 vessels per patient. I have never done FFR on 4 vessels, and I will never do it. It's not part of routine care. 2.25 millimeter vessel was, described as a stentable or graftable vessel. You could make arguments that, again, in modern day percutaneous intervention, implantation of 2.25 millimeter stents would be extremely low. The other thing is the patient population themselves, half of them were stabilized in STEMI, but actually 75% of them had 0 or 1 vessel disease. So quite a low risk group for a panacea of patients that half of them had an acute coronary event prior to that. So that's basically the outcome of the trial. And I think there's definitely food for thought, and I'll ask Aaron or Rob to give me their own thoughts on where they can attribute this to their everyday practice, and then I maybe finish off later on with my own thoughts of where this will go for the future.
Just a quick comment. Do you think it was designed for failure in a sense that, these low risk patients, and you're looking for improvement in quality of life? I mean, what would you expect in a low risk population? You're not really going to notice much change in the quality of life. And I can't understand why the hospital costs were more expensive. You're using extra equipment and time.
Yeah, the hospital cost not only was extra equipment and time, but it was recurrent visits to the emergency department, recurrent outpatient visits. So there was an accumulation of costs over 1 year.
Okay.
Yeah, I mean, I think you've always got to be careful when you've got cost efficacy as a primary endpoint. And there's a variety of reasons behind that, but mainly to do with the fact that cost efficacy is actually so difficult to do in, depending on considerable variation from country to country, depending not only on the costs, but how the reimbursement system works. And in some respects, I would say you should definitely have a primary clinical endpoint first and only have cost efficacy as a secondary endpoint. In this situation, they focused on cost efficacy and quality of life, and the clinical outcomes were a secondary endpoint of interest. And I think possibly from a trial design point of view, you should be looking at doing it the other way around. Now, notwithstanding, you could say that's an academic point, because the main story was that main message was that there wasn't difference in clinical endpoints between the groups. And I think you asked the question rightly, were they set up to fail? And I think to a certain extent they were. They biased the study towards a null effect by including a lot of these 30 to 50% lesions, particularly in non-LAD vessels. So we know 30 to 50% in LAD, of course, can occasionally be relevant, but 30 to 50% in non-LAD vessels, I think it's very unlikely. that you're going to gain anything by interrogating those, and vessels, small vessels less than 2.5 millimeter, as Tom said, including them, just increases the number of wire passages that you have to use using multiple pressure wires, contrast radiation. So, I think it was a difficult study, and I'm glad I didn't have to contribute any patients to it, because I could imagine it was a challenge to do in the cath lab.
Aaron, any comments?
Yeah, I mean, my personal feeling on this is that it doesn't reflect anybody's practice whatsoever. I mean, I think that Nick and Rod, have done well in actually trying to get this over the line and doing so many patients, for that matter. I'm not really surprised that the risk was increased in the FFR group, because, I mean, if you're going to go to the bother of trying to put various different pressure wires, some of them which are not very good at manipulating, that you're going to run into difficulties, especially if you're trying to do FFR of what has been shown to be non-prognostic vessels. I mean, if you're doing vessels of 2.25 millimeters, I mean, I always use the analogy with patients that if you cut the branch off the trunk, the tree doesn't die. And I mean, I don't think that prognostically that there's any value whatsoever, and I find it very hard to believe in the vast majority of cases that patients actually get symptoms from very small branches, because we all know that when we're doing these things that we often treat major epicardial vessels, we often impede blood flow in significant sized side branches, and the patients come back with absolutely no symptoms whatsoever. And so I'm not really sure what the purpose of it was. I think that from the registrar's point of view, Vinny, I think from the registrars on the call here, I think one of the things that you must do is, if you have doubt in your angiographic evaluation, that you should use an adjuvant diagnostic tool to bring some objectivity to that assessment. Because too frequently I would sit in angio review meetings or heart team meetings, and I would have colleagues all sort of arguing about percentage stenosis. And I don't really know what this love affair is with percentage stenosis, quite frankly. I think it should be banned from our vocabulary, because, I mean, if you look at the original FAME2, the FAIR studies, these studies were all based on angiographic evaluation from 30 to 90%, because the variation in assessment by eyeball assessment by cardiologists was just so wide that people talking about 30 to 50 and 50 to 70, I think it's real. I think it's nonsense, to be quite honest with you.
Would you argue, I mean, compared to the US, where they maybe do 2 or 3 times the functional studies before they do the angiograms, we in Ireland tend to do the angiograms and we have less of the functional studies. So are you arguing, Aaron, that you shouldn't be guided by what you see, the ocular stenotic reflex, you should have additional modalities to assess for ischemia?
I think if you're looking at an angiogram and you're standing with a colleague or a registrar, and there's any debate whatsoever as to the significance of a lesion in a major epicardial vessel, that you should make some form of assessment, and probably FFR is the gold standard for that.
Provided it's above 2.5.
Well, I mean, people have debated this for a long time as well, and be interested to hear what Robert and Tom think. What is the sort of size of a vessel that is prognostically significant? Because, I mean, people have argued about 2.5, 2.8, et cetera, and vast majority of the time we never formally measure the caliber of the vessel anyway. So again, it in itself is done through an eyeball assessment.
Okay, guys, I think we're nearly at the end of time. Tom, did you want to say anything final on the Ripcord 2 study?
I mean, just to follow on from Aaron there, actually 15% of the angiography arm of that study went on to have a different, imaging study, whether it be a nuclear CMR, etc., whereas only 2% of the FFR group went on to have anything further done. So that just highlights that this is not poo-pooing FFR. FFR is actually an excellent and valid technique, but it has to be used in the appropriate vessels at the appropriate instances in the appropriate time.
Okay, Tom, so from this study, Ripcord 2, your summary take-home message is FFR shouldn't be used across the board at the time of routine angiography, unless you've got serious concerns about intermediate lesions. Would that be?
Exactly. I think this concept of pan FFR for all vessels is futile. It doesn't reflect day-to-day practice.
Yeah.
It doesn't reflect real-world intervention.
Okay, Rob, let's get your, we're coming to the end, guys. So,
yeah.
Rob, Master DAPT, take-home message.
So I think Master DAPT, probably the take-home message is as simple as less is more. But in these high bleeding risk patients, we've become more comfortable with shorter duration DAPT if we need it because the patient has high bleeding risk. If the patient doesn't have high bleeding risk, then we need to stay with the guideline recommended standard DAPT durations.
Okay, Tomahawk. Aaron, any thoughts?
I would just say
what's your take-home message, or have we?
I think it's very much in keeping with what we all thought at the beginning, in that we probably should be selective in the people that we take for coronary angiography to the, because the immediate, trigger finger reactionary thing to do it is probably not going to be of benefit to patients. And if we let the dust settle, I think that we'll be doing, the patients will do perfectly well.
Okay. Well, look, thank you all. I am sorry to the audience who may have sent in questions. They haven't appeared here in front of me. But basically, I think this has been an excellent session. It shows you the thought process that go in, even independent of the actual intervention. It's the decision making, and it's so important. And it affects all of us, regardless of whether we're interventionalists or non-interventionalists. So again, it's my pleasure to, on behalf of the Irish Cardiac Society, to thank you all for participating. Special thanks to Tom and Rob and Aaron for their expertise, and enjoy it. And we look forward to seeing you all at the Irish Cardiac Society. Thank you all.
Thanks, Vinny.
Okay.
Thanks. Bye-bye.
Bye-bye.